Joining us now, Dr. Debra A. Smith. She's the author of the new book, Healthcare Solved. Oh, thank goodness. Real answers, no politics. She joins us now. Dr. Smith, how are you? Thanks for coming on the show.
Very good. Thank you, Ben.
What is the largest misconception, misdirection about the healthcare debate? As somebody who understands it a lot, when you read the paper every day, when you watch the news at night, what do you think? What makes you pinch the bridge of your nose and shake your head?
Well, that's an excellent question. One of the things, I think it's probably a misconception, and it's an understanding of what will a public option get us, or will it get us where we want to go. I think the politicians have told us we shouldn't fear a public option because programs like Medicare work very well. Our elderly are very happy with it, and Medicare does provide good benefits. The issue with Medicare is that the working population pays for the current retirees. And the program has, when it was first instituted, first of all, now Americans are living over 4 years longer than they were in 1965, and the percentage of the population that's eligible for Medicare has also jumped. It was about 9.5% when it started, and it's about 13% now. And in the next 20 years, it will expand to 19%. So you can see how that can possibly be a problem when, like I say, the current working population are paying for the retirees. The major issue is that the present value of the unfunded liability for Medicare Part A, which covers hospitalizations, is $34 trillion, according to the chief of the Federal Reserve Bank of Dallas. For Medicare Part B, which covers doctors, another $34 trillion, and Medicare Part D is $17.2 trillion. This is a grand total of $86 trillion, which is currently unfunded. And you say to yourself, Jiminy Crickets, how did we get this far off?
Just for the record, I don't say Jiminy Crickets.
Okay. Well, some of it's due to longevity and, of course, the demographic shift as we've got a large segment of our population, the baby boomers now reaching retirement age. But the other issue is we've expanded benefits to cover more things, and we have new medical technology, which is quite costly.
Okay, so I get it. You've set up that there's a huge money problem.
Right, right. So, well, if we look at it and we say, well, where does the money actually go? And 85% of the money actually goes, if you look at the private sector, for example, 85% of the money goes to pay claims, which is known as the medical loss ratio. Another 10% goes to administration. Nonprofit insurers, like, for example, my old employer, Highmark Blue Cross Blue Shield, explicitly stated they kept their medical loss ratio at 90% because they're a nonprofit insurer. Nonprofit insurers are given their tax status because they provide what's a needed, quote, needed public service. And they're good for the industry because they keep the for-profit insurers honest in their premium pricing. The for-profits, then, their incentive is to reduce administrative costs to increase their profits, and which is also good because it keeps the nonprofits from passing through the administrative costs to the customer. Now, the politicians claim that the public programs have cheaper administrative costs than the public sector, but the true issue is, and they say, therefore, a public program will give the people perhaps a cheaper option, or at least a more honest estimate of what the cost of health care provision should be. And the truth of the matter is, and I think it's because perhaps this administration is still new and young in their early in their learning curve, but the truth of the matter is, right now, the Centers for Medicare and Medicaid, they pay third-party administrators or insurers to pay claims. There's no one in the federal government who directly pays claims. And in 4 of the last 5 years, CMS requested $580 million to combat fraud, waste, and abuse, only to waste, and government, and of course Congress refused it, but it's estimated that they wasted $29 billion in improper payments.
Well,
so when
Well,
sorry.
I hear you, and I'm hearing what you're saying,
right.
But so your book is called Healthcare Solved.
Right.
What it sounds like to me is because you're suggesting that what we have now. I mean, when you say that the nonprofit, what was the group you worked for?
Sure, I worked for Highmark.
Which you said nonprofit, right?
Right.
Which kept that 90% went to claims.
Right.
And that effectively competed with the for-profit healthcare companies, insurers, to keep their costs down. But the cost of premiums have gone up 119%. So where's the solved part of this?
Right. Well, the solved part of it, yes, premiums have gone up, but there's two things that account for premium cost. Number one, you have the experience rating. In other words, what is your experience with the insurer's experience with that group? And that may be anything from, you know this, from auto insurance. To get into an accident, your insurance premiums go up. In other words, they try to predict what the claims might look like in the given year, given the age of the employer group, the past claims data, and the diagnosis. The second thing they try to do is predict the increase in medical costs. So our population is getting older, number one, and the second part is the cost of actually providing care are going up,
well, Debra,
which is why it's gone up.
Dr. Smith, sorry to call you Debra.
No, it's fine.
All right. Dr. Debra Smith.
Yes.
Again, your book is called Healthcare Solved.
Right,
What you were
exactly.
so far what you've argued to me is that the current system is a lot better than any system that includes a public option.
Well, no. What I would actually argue for, or at least advocate, is that we have something like a privately run, government-defined group benefits plan that small employer groups, because particularly employer groups under 50.
Are we talking about this? Are these sort of the healthcare co-ops that Senator Conrad
No,
was
you
talking
don't
about?
need a cooperative. That's the misconception. Is we already have a privately run, government-defined group benefits plan. When we look at Medicare supplemental insurance, it's a similar type product. It has about a dozen or so options which to choose from. Anybody over the age of 65 can buy it from any carrier licensed to sell it in their state. Now, you might have a slightly better price if you're with a group such as AARP, but other plans are still very competitive. It may be $1 or $2 difference a month, but there's no need to join a group. And as a matter of fact, I would advocate against co-ops because they take both a considerable amount of time and money to build. And frankly, why spend the money we don't have?
Right. Do we need health care reform, Dr. Smith?
Yes, we do. We absolutely do.
And what would happen in that health care reform? I mean, can we?
We do. We can't continue to have
we can't continue to have whatever 40 to 50
double-digit
million
inflation, right?
Well, not double-digit inflation. 40 to 50 million people without health insurance. I mean, is that a problem that you want to see rectified?
Oh, absolutely, absolutely.
And but I still don't quite get how we're going to do that.
Okay.
In your mind, I mean, because you obviously you think that the healthcare plan advocated by the inexperienced administration, as you said, is clearly in your mind not the answer.
Well, I think that there are better ways of doing it, and I think the first thing that we have to do is to actually decrease medical costs. And I think that one of the first ways that we have to do that is if you look at it from what is good quality medical care. I mean, we all want to have, what we want to have is a system where we get patients better, faster, and cheaper, right? Mm-hmm. And do we actually know what good quality medical care is? And the answer is sort of, but not really. If you look at care for, first of all, 30% of the costs occur actually as a result of 1% of the population. The next 11% of the population accounts for 43% of the costs. So who
are those people who are chewing up all the costs?
Sure. The 1% accounts for mostly patients with cancer, unfortunately. And the other 11% 11% of the population accounts for people who are having transplants, people who are having joint replacements, people who have perhaps they have coronary artery bypass grafts, those kinds of things. So
I was going to say coronary artery bypass.
Right.
It's on the tip of my tongue. I couldn't. By the way, I'd like everyone to point out I couldn't even repeat it to you.
Well, actually, the fact of the matter is, if we could figure out how to best cover those catastrophic, those endpoints of disease. In other words, it's not your high cholesterol that costs a lot of money. It's the fact that in the end you need a stent put in one of your arteries, or you need bypass surgery.
Right.
That costs the big dollars. If we could actually find out who has achieved the best care and what the best quality of care is. I mean, even the AMA admits this in their letter to, they had written a letter to the president. We need to define what is quality. The issue is that if you compare across specialty groups in this country, you'll find that different specialty groups treat different disease entities differently,
right,
and have different standards. If you look at it across countries, across first world countries, you'll see that they all have different standards. And if we could figure out who has actually found the best care, and in my book I propose a detailed way of doing this, but if we can determine who's actually found the best care, and you will see that certain countries do have a competitive advantage in treating certain diseases over other countries, we would know it. We'd be able to save a significant amount of money if we could find that out.
Well, I got to ask you, and by Debra's book is called Healthcare Solved, Real Answers, No Politics. But before we let you off the hook with the no politics, you work for an insurance company now? Do you?
No, I do not. I'm self-employed.
Self-employed. You're not paid by any insurance agent. You're not.
No, absolutely not.
So genuinely no lobbying stake here to
no
slow
lobbying
or
stake
kill
whatsoever.
All right. All right. Well, anyway, the book "Healthcare Solved: Real Answers, No Politics." Obviously, we need answers. Lord knows, I need answers. I am. There's no question. I feel in over my head on this issue, and the numbers that you get hit with are enormous. I do think we're talking about the issue wrong, in general. I don't think it's framed wrong, but Debra, thanks for helping out to the extent that you could, and good luck with the book, and good luck as you continue talking about it.
Hey, thank you, Ben. I appreciate you taking my time to interview me.
All right, thanks a lot. Okay.